my name's Helen Bethell. I'm a Registered Genetic Counsellor here in the UK, and I work part-time for the NHS and have recently begun working part-time for the Haemochromatosis UK charity. Today I'm going to deliver a webinar about what is genetic counselling. So I'm going to look at firstly the history of genetics and talk about how the science has developed and how the role of a genetic counsellor has emerged. I'm then going to go on to talk about exactly what a genetic counsellor is, who they are, where they are, how they work, what they do, and when they do it. So firstly, a little bit of a history. So genetics has been around for centuries. So farmers have been selecting breeds of animals to breed together and produce certain traits and products. So it's been known about for years, it just didn't have the title of genetics. And back in 1859, a scientist known as Charles Darwin started his studies looking at and started writing about natural selection. So he started noticing that within nature, animals and creatures might have certain traits which were more suitable to particular environments, and therefore they were being selected and survived better because of those traits. Around a similar time, there was a German monk known as Gregor Mendel, who was a keen gardener in the monastery where he lived. And he started to note that there were certain traits that could be predicted when he was crossbreeding some of the plants that he had in his allotment. And he started to realise that traits could be predicted in a particular ratio, and that Gregor Mendel is considered the first person to have noted about in traits can be inherited. Not so long after, in 1869, DNA was actually extracted from the cell, and DNA is the thing which encodes for our genetic instructions. So it's the thing that the chemical which sits in the middle of the cell, which encodes for our DNA. They didn't know what it was at that time, but they were able to extract it, and they knew that it was something to do with inheritance and the instructions from the cell. Fast forward to 1953, and a team were able to correctly identify the structure of that DNA that had been extracted. And within a couple of years, the first disease gene was identified. So it was the first gene, the first genetic instruction that was found to be linked to a disease, and that was sickle cell anemia that was for. In the next couple of decades, up until the 1970s, machines were being developed to try and read or sequence, as we call it, the genetic code. So that is where we try and look at the sequence of the genetic code and look what order it's in, although the interpretation of what that code means is another part of the process. So in 1975, machines were being developed to sequence this genetic code, and in 1990, the first human genome project was launched, and that had the aim of reading the entire genetic sequence, the entire genome of one single person. And as you can see from the slide, it actually took 13 years to be able to achieve that. So one person's DNA to read it from start to finish and to read that code. Where we are today, so in 2020, we're actually able to do a full genome sequence within 24 hours. So what took us 13 years back in 1990, we're now able to do within a day, sorry. However, what that code exactly means, again, is another part of the process. And that's where we are today in genetics, is trying to interpret that information that we can read into useful information. We now know, so from 1955, where we found the first sickle cell anemia gene, we now know the thousands of genes which are associated with diseases that we see. Just out of interest, in 1996, the gene which causes hemochromatosis, the HFE gene, which stands for high iron, was found on chromosome 6. So chromosomes are like the filing cabinets where our genetic information is stored. And in 1996, the specific genetic instruction, which is altered in genetic hemochromatosis, was identified. So throughout all that history, you can see that within the last couple of hundred years, our knowledge of genetics has dramatically increased. And from around the 1970s through to the 80s and 90s, clinical genetics, which is a genetic service within the health service, which tries to understand disease and genetics and how they interact, was starting to emerge. And through that, through doctors trying to make diagnoses and trying to help inform patients about the genetics which are causing their disease, a role for a support person and a person to help families come to terms with the information that they have and to undergo testing and make informed decision was also emerging. And that's the role today that we consider as a genetic counsellor. Now, traditionally, in years gone by, this was very much a nursing role. So it may have come out of a nurse or a midwife who maybe had a special interest in genetics, and so ran a specialised genetics clinic within their setting, and maybe eventually moved into clinical genetics. But in the early 1990s, in 1992, the University of Manchester set up a Master of Science MSc degree for people welcoming applications from nursing and science backgrounds to study genetic counselling. And that has been running now since 1992, and other universities now offer that training. If anybody is interested in finding out more information about training to become a genetic counsellor, there's a link at the end of this presentation where you can find out more information about that. So back in the 90s, genetic counsellors were studying the MSc and were coming out qualified with backgrounds in either nursing or science. In the early 2000s, it was recognised that those who were qualifying through the MSc route who had a science background weren't necessarily regulated. So those with a nursing background were registered with nursing bodies that were established and made sure that nurses were competent in the work that they were doing. However, those with a science background didn't have any form of regulation, and therefore in the early 2000s the Genetic Counselling Registration Board, or the GCRB, was established, and that is still running today. So after people have qualified as a genetic counsellor, they are requested within the UK to qualify to submit a portfolio of work, which normally takes about 2 years to accumulate. The portfolio is a mixture of caseload as well as academic pieces of work and writing. And once that is approved, then that person is considered a registered genetic counsellor, and their name is entered onto a register of genetic counsellors, which can be accessed by anyone. And I'll come back to that in a little bit. So I just wanted to touch on the terms genetic counselling versus the term genomic counselling. So traditionally, genetic counselling is a term that has been broadly used. Occasionally, people might refer to themselves as a genetic nurse, but genetic counselling is the more widely accepted term. However, as I've mentioned already, genetic testing is changing. So it's gone from being where we do specific genetic tests, where we look for specific changes, and we still do quite a lot of that testing, versus testing where we are testing a more broader range and more widespread testing, a more genomic approach. So rather than considering particular genes, we are considering a person's whole genome. And as testing and our approach changes, genomic counselling has become a more used term. So throughout this presentation, I might use those terms interchangeably because they are one and the same thing. However, as we move into a more genomic era where we're doing these more widespread testing, genomic counselling may become the more preferred term. So where are genetic counsellors? Where can you find us? So within the United Kingdom, obviously we have our fantastic national health system, and therefore a lot of the genetic counsellors within the UK, the majority are located within regional genetic services which fall under the NHS. There are a small number of genetic counsellors who work in a private setting, and I just wanted to draw your attention to the fact that genetic counselling as a term isn't actually a protected title, so actually anybody could use the term genetic counsellor. However, registered genetic counsellor is a protected term. Therefore, if you are due to see somebody who is calling themselves a genetic counsellor, it's important that you check that they are on the register of registered genetic counsellors to ensure that they have the skills and the training that are needed in order to be able to give you the right information and accurate information, and to ensure that the service you're receiving is a safe one. So that can be accessed, the register can be accessed on the link on the website, on the slide. However, as I said, the majority of genetic counsellors within the UK are located within the National Health Service. So clinical genetics forms part of a tertiary service. So in the National Health System, you have your primary care, your GPs, you have your secondary care, which is your hospitals, and you have services that are considered tertiary services, such as genetics, where they are specialised services, and because numbers are low, they're run in regional services. Now, some genetic services cover large geographical areas, whilst others cover quite small geographical areas because they're densely populated. So, for example, in London, there are several genetic services located within there, whilst the Northern Genetic Service covers right up to the borders of Scotland, right down to Yorkshire, and Cumbria as well. So it covers quite a broad range. And if you wanted to know more about your local genetic service, you could find that on the website link that's shown there, the British Society of Genetic Medicine, and that link's also given at the end of the presentation. So how genetic counselling works? Well, first of all, we need to think through how referrals are made and how they're received by genetics. So referrals can be made by primary care GPs or by secondary care, and they're made when a doctor or a nurse might suspect that the pattern that they're seeing in front of them, or the family history which is being reported by the patient, might be suspicious of an inherited tendency or of genetic factors. So they might suspect that there's more going on than just chance in this patient, that there might be genetic factors that are playing out here, and therefore there may be risks, not just to the patient in front of them, but also to their wider family. So referrals are made and received, and this is where services may change depending which regional genetic service you refer to. However, broadly speaking, referrals are usually dealt with in one of two ways. So the first one is that the referral is received, an appointment is sent straight away. The second pathway is that rather than being sent an appointment straight away, you're asked to complete some information, a family history questionnaire, before you're seen, so that the information can be collected by the genetic counsellor or the clinical genetics team. A risk assessment can be made based on the information that has been collected, and then from there you may receive a letter explaining your risk, or then you may be invited again to make an appointment to discuss that in more consideration. Common genetic conditions are not necessarily always seen by genetics now, and I'll come on to a little bit about that towards the end of this presentation. So what we see into. So genetic conditions can arise by alterations to chromosomes. So chromosomes, as I touched on before, are the filing cabinets which hold our genetic information, and they're arranged in pairs because we get one set from our mother and one set from our father. And so you can see on the picture here that there's 23 pairs, and the last pair are the sex chromosomes which dictate whether you're male or female. So on the slide, it shows that this person has an X and a Y and therefore is male. So alterations to these chromosomes can cause disease. So it may well be that these chromosomes have a little bit extra information on them. It may be that they're missing a little bit of information, or it may well be that they've got a bit of information that's been switched around a bit. And all those things can cause genetic disease, and so there are genetic conditions, and therefore somebody may be referred to genetics, and we may be able to do some testing which can identify what has happened to the chromosomes. And it would then mean that if we're able to identify that in a family, we could then say to others in the family, do you want to know whether you've inherited this or not? And in a similar way, but in a more specific way, we can actually look for specific genes. So genetic conditions can arise where you have simply one letter that is wrong in a genetic code. So one letter that is wrong may alter the protein that it's encoding for, which is the unit that is working within the body to carry out a particular function. One simple spelling mistake may alter that protein, which means that it's unable to carry out that function, and therefore it's causing symptoms and therefore a genetic condition. Or it may well be that there are several genetic factors, so there's not just one particular chromosome that's altered, there's not just one gene that's altered, there may be several genetic factors that are working together and may even be interacting with the environment. So genetic conditions can arise by different ways. The areas of work that a genetic counsellor sees, again, varies between genetic centres. However, generally speaking, workload for genetic counsellors is split into two categories, into cancer and into general. So the work that we do with cancer is looking at family histories where there maybe is a lot of cancer. So cancer is a common thing. So 1 in 3 people will develop cancer in their lifetime. But in some families, there's more cancer than you would naturally expect to find with that 1 in 3 statistic. So we know that particular inherited predispositions to cancer include things like BRCA1 and BRCA2 and Lynch syndrome. So those occur in about 5% of families where we see with family histories of cancer where they have a specific genetic spelling mistake. And the advantage of being able to assess a family history and identify those specific spelling mistakes is that we can then say to relatives of those people, do you want to know whether you've inherited this or not? And also we can be very specific about management for those patients. It may be that we never get to the point of finding a specific genetic spelling mistake, but we are able to put people into a risk category of low, moderate or high and be able to recommend screening for them that is appropriate to that level of risk. In terms of general genetics, that encompasses everything else. There may be specific specialist areas within general genetics. For example, there may be muscle conditions, conditions involving the eyes, neurological conditions, and lots of others. So there may be specialist areas, but general genetics generally involves everything else. Prenatal is also an area of work which genetic counsellors become involved in, and that might be in helping people either to plan a pregnancy and consider treatment, which might mean that the genetic condition isn't passed on, or it may well be that they're already pregnant and that we're organising testing in pregnancy for them to work out whether the baby is affected by the genetic condition. So on the slide are a list of questions. Is my condition inherited? What can be done to reduce the risk? Do I want to know if I'm at risk? Could I have prevented this from happening? Can anything be done to prevent this? Have I passed this on to my children? How do I explain this to my family and my children? Are other members of my family at risk? What has caused this to happen? And is my condition inherited? All these are questions which are common questions which are put to genetic counsellors, and often the questions that counsellors try to answer. When you are ill and you go to your doctor with symptoms, then you may be offered testing. Genetic testing is very different to those kind of tests which you might be offered if you're experiencing symptoms. And it might be different for two main reasons. The first one is that when we do genetic testing, you might not yet be having symptoms, and therefore in some ways we are actually predicting whether you are going to develop symptoms or not. And for some patients, they do want to know this information. They want to know so that they can be prepared, and so that they can take any measures that they can in order to reduce their risk. For other patients, they don't want to know this information. It's very difficult to live with and might feel that they're waiting and they've got a ticking time bomb by knowing that they have this condition. The other way that genetic testing alters from testing that you might access via your GP is that it not only gives information about you and your health, but it also reveals information about your relatives. It might tell you your parents are at risk. It might tell you your siblings, or even that your children, that you might have passed this on to them. So genetic testing can often be a very emotive process. Patients can often struggle with the emotions that it can cause. And genetic counselling is there to help support patients with these emotions and help consider them when they're considering whether or not to have genetic testing. That's part of the reason why we have counselling in our title. So although we're not counselling per se, although many genetic counsellors have got counselling qualifications, the genetic counselling isn't counselling specifically. However, we use a lot of the skills and a lot of the methods of counselling to help patients to explore their feelings and their emotions to ensure that they come to a properly informed decision that's going to be the right one for them to live with. So what is involved in an actual genetic counselling session? Well, every single session is different, although there can be similarities drawn. So generally speaking, every genetic counselling session will be centred around the agenda that the patient has, so the questions and the concerns that they have. So it depends what the patient brings into the room and what their family history is in terms of what is covered in that session. It can also vary between different genetic centres and where it's located. So typically most sessions are between 30 minutes to an hour. They're usually located within a hospital, and they may involve some information collection, particularly if you haven't sent in a family history questionnaire already, then you might be asked to give a family history within the clinic. The session might also involve some information about risk assessment and management, about risks to your relatives, about risk to your children, information about inheritance and how this could be passed on and what the risk is for your children and for your siblings. It might also be a discussion about advice about testing. So is there testing available? And if there is, what that involves. Just to note, genetic testing isn't available to everybody. So genetic testing is still relatively expensive, and therefore there's usually criteria to be met. So what I would say is just be prepared that you won't necessarily be offered testing if you have a genetic counselling appointment. You may also be offered follow-up appointments. So some patients are seen in a series of appointments. Some patients just need a one-off appointment, but that can be flexible usually depending on the centre that you're seen at. So when do we see patients? So on the slide is a circle, and you can begin at any point. It covers pregnancy, it covers birth, childhood, adolescent, adulthood, and family planning. And genetic counsellors will see patients at all points of that cycle. In pregnancy, there may be abnormalities which are detected by population screening, such as scanning, when somebody is already pregnant, and it may flag up that those are symptoms of a genetic condition and may indicate that there's genetic factors going on, in which case that couple might be referred to genetics for an exploration of that. Or it may well be that we see the family for testing in pregnancy, so it may well be that we know a specific genetic condition within the family, and therefore there's certain testing that we're able to carry out. It may well be that we see a child at birth with their parents. So features at birth, again, might suggest that there is a genetic condition and that there are genetic complications going on and might indicate a diagnosis. Or it may well be that we know the genetic condition in the family, that the couple may have opted not to have any testing in pregnancy, but have decided to have testing at birth. Testing at birth for a known genetic condition is only offered when there is treatment available, if it's an early onset condition. If it's an adult onset condition, then testing is only offered from the age of 18. In childhood, children might develop learning or behavioural difficulties, which once again might indicate that there is an underlying genetic factor in the family, and they may be referred to genetics to try and work out what that is. In adolescence, so at the age of 16, people are considered to be Gillick competent, which means that they're old enough to be able to give informed consent. So at the age of 16, carrier testing for recessive conditions such as haemochromatosis are offered. However, those genetic conditions which are dominant conditions, so actually cause symptoms in the patients that we see, then and if they're adult onset, then testing isn't offered until they're 18. So in adulthood, as I've just mentioned, predictive testing for adult onset conditions is offered from the age of 18 onwards. And it may well be that we see patients in adulthood in order to help manage their risks and their screening. And finally, family planning. So genetic counsellors maybe get involved with couples who are planning a pregnancy, where there is a known genetic condition, where they are planning what their risks are and what their options are for pregnancy, and in particular maybe planning for the use of pre-implantation genetic diagnosis, which is a specific form of IVF which can be used for genetic conditions when the condition is licensed for that use. So genetic counselling and haemochromatosis. So we've talked about the history of genetics and we've talked about what genetic counselling is, and I just wanted to go on and talk a little bit about genetic counselling and genetic haemochromatosis. So historically, all patients with genetic conditions were seen by genetics, and that included haemochromatosis. However, as I've talked about throughout this presentation, the testing ability that we now have has dramatically increased in the last decade or two. This has meant that there's been issues with capacity within genetics as we're being demanded for more complex and specialist roles. Therefore, common autosomal recessive conditions such as haemochromatosis, where the management of symptoms is already carried out by primary and secondary care, and genetics is only really involved in terms of the management of the genetic testing. In these scenarios, genetic testing has been passed back to primary care in order for them to manage it. So now GPs can request testing for conditions such as haemochromatosis. So any relatives or yourselves who need testing should be able to seek that from the GP. This pathway is sufficient for most patients with a family history of haemochromatosis. However, there are others who may be experiencing some of those emotions that I touched on earlier, those feelings of guilt or anxiety that people may be experiencing around testing. And therefore, there's two possible options of trying to access genetic counselling. The first is the traditional way of requesting a genetic referral from your GP, and it's important that your GP specifies exactly what it is you've got questions about and exactly why it is you need genetic counselling. Otherwise, the referral might be bounced back to the GP, who might be given advice about how to advise the patient. The other way is that members of Haemochromatosis UK from April this year have access to some genetic counselling, as in the next few weeks I'll be beginning some genetic counselling sessions in order to offer support to members of the charity. So more information. So if you'd like more information about haemochromatosis, then this can be found on the haemochromatosis website given on the slide. Again, the Genetic Counselling Registration Board list of registered genetic counsellors can be found on the GCRB website. And the Association of Genetic Nurses and Counsellors is our professional body and has more information about what genetic counselling is and how to train to become a genetic counsellor. For more information about training to be a genetic counsellor, as well as the AGNC website, there's also the Health Careers NHS website, which again is given on the slide. And finally, the last link there is the British Society of Genetic Medicine, which gives links to local genetic service. So I hope you found that helpful. That was a whistle-stop tour of what is genetic counselling.